Welcome to the CAA 2021 webinar series. Today's webinar is Public Access Defibrillation, Impact on Patients and Responders, presented by Professor Karen Smith and proudly supported by Philips. Thanks for joining us and please enjoy.
Welcome to the latest in the CAA webinar series. My name is David Waters and I'm the Chief Executive of the Council of Ambulance Authorities. Today's webinar is titled Public Access Defibrillation, Impacts on Patients and Responders, and is proudly sponsored by Philips. The impact of early defibrillation on survival from cardiac arrest is well established. Public access defibrillation, also known as PAD or PAD, improves survival outcomes, but is it also associated with improved quality of life? How do we maximise early CPR and PAD through volunteer responders, and who should we recruit? Is there an impact on lay responders dispatched to cardiac arrest cases? Today's speaker is Professor Karen Smith. Professor Smith is the Director of the Centre of Research and Evaluation at Ambulance Victoria, or AV, as we like to call it. Karen is an epidemiologist with extensive experience in the epidemiological analysis of patients accessing ambulance care and in the design and implementation of clinical trials. Karen holds adjunct professorial positions with the School of Public Health and Preventive Medicine and the School of Primary Healthcare at Monash University. Professor Smith has attracted over 26 million Australian dollars in competitive grants in collaboration with ambulance services, hospitals, universities, and other organisations. Karen is currently a chief investigator on a number of large multi-centre trials and centres for research excellence. Professor Smith co-founded and chairs the Victorian Cardiac Arrest Registry, which contains information for all patients in Victoria who suffer cardiac arrest and receive ambulance attendance. Karen also co-founded the Victorian State Trauma Registry at Monash University and sits on the steering committee. She is a chief investigator on the Unexplained Sudden Cardiac Death Project, a registry exploring the causes of sudden cardiac arrest in patients aged under 50 years. Karen has built up an internationally recognised pre-hospital research department at Ambulance Victoria. She has published over 300 journal articles and 2 book chapters, and was recently awarded a Top 50 Public Sector Women 2020 award by the Institute of Public Administration Australia. This award recognises individual excellence and achievement of exceptional female leaders and their significant work. Congratulations, Karen. Karen is a long-term friend of the CAA and contributes extensively to many of our committees and is a regular presenter at the CAA Congress and at the CAA Global Resuscitation Alliance conferences. Please join me in welcoming Professor Karen Smith. Welcome, Karen.
Hi, I'm Professor Karen Smith, Director of the Centre for Research and Evaluation at Ambulance Victoria and also an adjunct professor with Monash University. I also have the privilege of chairing the Victorian Ambulance Cardiac Arrest Registry, and it's my absolute pleasure to present to you today a webinar on public access defibrillation, something that's very close to my heart, and I thank the Council of Ambulance Authorities for inviting me to speak on this important topic. So we all know, and I'll be speaking to the converted, that VFVT is a time-critical emergency. We know that the probability of presenting in a shockable rhythm declines with increased time to first defibrillation, and the probability of survival decreases with increased time to first shock. But there's not great evidence around whether the quality of life is influenced by how quickly patients are shocked. And also, how is PAD functioning in key locations in Victoria? And findings from that can be extrapolated to other states and internationally. How do we maximise public access defibrillation? And what is the impact on first responders? So again, just highlighting that VFVT deteriorates into a non-shockable and therefore a non-viable rhythm over time. So this is data from our Victorian Ambulance Cardiac Arrest Registry, and we can see that the red bars are patients who received bystander CPR, and the blue are patients who did not receive bystander CPR. And we've divided it up into, and these are patients who are presumed cardiac cause presenting in a shockable rhythm. And we are looking at how quickly EMS get there. And we can see that if paramedics are there quickly, within 6 minutes, that almost 40% of patients are found in VFET if bystander CPR is applied. And you can see that bystander CPR is actually ameliorates to some degree the impact of delayed response time, where we can see that there's not a rapid decline in the percentage of patients presenting in VFET, which can't be said with patients who don't receive bystander CPR. And then this last one, where there's extended response times greater than 21 minutes, are likely to be patients who arrest after the actual cardiac arrest call. So as well as seeing a rapid decline in the proportion of patients who present in VFET, survival also rapidly declines with time to first shock. So as time to first shock increases, we see a significant decline in survival. And again, this is data from our Victorian Ambulance Cardiac Arrest Registry. And we can see we have survival up around the 70% mark if defibrillation is applied within 5 minutes. And this rapidly declines as response times are extended, and survival is 12% if response times are greater than 15 minutes or time to first shock is greater than 15 minutes. So we really need to be getting patients in these first 5 minutes to maximise survival. And that's very challenging for emergency medical services or ambulance services because, resources are a finite, ambulances are a finite resource and demand is ever increasing. So we need to innovate as to how we can get defibrillation to patients rapidly. And if we look again at data from our cardiac arrest registry, we can see that there's differences in survival percentages depending on who has actually applied the first shock in patients in a shockable rhythm. So if you're defibrillated by paramedics, you have a 30% chance of survival. And this is from our annual report, which covers data from 2019 to 2020, and it's publicly available on our website. And you see a similar percentage of survival if you're shocked by first responders, and by that we mean our firefighter first responders or our community emergency response teams, so teams that are integrated into our response and dispatched on behalf of ambulance. But if patients are defibrillated by a public access defibrillator, survival rate is last year was 56%, and we've seen over the years this survival can fluctuate from around this to over 70% in our PAD cohort when we look at VACAR. And this is another demonstration of the probability of survival, but also survival with neurologically intact survival. So this is from Seattle data, and again it shows that the proportion of patients who survive with neurologically intact significantly declines. It's ameliorated to some degree by bystander CPR, which is the black line, but after sort of over 15 minutes or more, the probability of survival is significantly low. And again, this is another graph just highlighting this from international registries. This is from the Japanese registry, and looking at CPC 1 month after the cardiac arrest. And you can see really there's significant decline as collapse to shock time increases. Again, better chances or higher probabilities of a good outcome if bystander CPR is applied, but you still see this rapid decline as time goes on. So this importance of early CPR and early defibrillation have led to people to sort of emphasise that not all links in the chain of survival are even. And Charles Deacon published this in Resuscitation a few years ago, sort of highlighting the importance of early recognition and early CPR. And the biggest numbers of patients that you're likely to influence are in the early links, and the number of patients whittles down as you get to things like post-ROS care. I would argue that early defibrillation should actually be a bigger link, because our data and a lot of data internationally just shows that definitive treatment is so important. So just to give you a bit of a background on Ambulance Victoria, because I'll be presenting data from AV, most people would know it. It services all of Victoria, so around 6.4 million people, the majority of whom reside in Melbourne. And we see over 650,000 emergency road incidents per year, around 1% are cardiac arrests, so around 6,500 cardiac arrests per annum, which equates to around an incidence of around 124 per 100,000 adults. We definitely see a higher incidence in rural areas per population, and this incidence has not declined and has remained fairly stable. In fact, has increased over the last decade or so. And we use MPDS for 000 call triage, and we also have a secondary triage service. When we look at our response specifically to cardiac arrests, so it's obviously allocated a priority 0 event in our 000 call taking and dispatch. This will elicit a multi-agency dispatch where available. So we'll have fire first responders or community emergency response teams, the closest ALS ambulance, the closest MICA, and now lay public via the Good Sam app. So I'll just give you a little bit of information as well about our Victorian Ambulance Cardiac Arrest Registry, of which our annual report is available on our website. We're the first ambulance service in Australia to start publicly reporting via an annual report. So it's a clinical quality registry. It's been collecting data on patients since 1999, and we have now almost 120,000 cases in our registry. It's based on the internationally recognised Utstein template and has over 300 variables in the registry. And we supplement it with hospital discharge data. So this is quite a labour-intensive process with ethics approval from over 100 participating hospitals. And we also have some coronial data where we look at etiology and cause of death, originally for discrete projects, but we're now commencing regular linkage with the coroners, which is fantastic. And one thing that I'm particularly proud of, so for the last 10 years, VACAR has been collecting health-related quality of life outcomes on adult survivors at 12 months post their cardiac arrest. And we're the only registry in Australia to do that, and we're one of the few registries internationally to do that. And I'll talk about that in a bit more detail in one of the studies I'm talking about. So we know that time to defibrillation is crucial, and so one of the questions to ask is how is PAD performing in some key locations? And I'll just highlight that the work for all of the studies that I'm presenting today from VACAR is actually done by PhD student Brian Haskins, who has used the VACAR registry to answer some key questions around public access defibrillation and first responders. So this is Brian's work essentially. So one thing that happened in 2019 was that Woolworths made a big announcement that they were installing public access defibrillators in all of their stores, which was fantastic. And this was then closely followed by Coles making the same announcement. So after that announcement, we thought we would look at, use VACAR data to look at actual cardiac arrests occurring in supermarkets. And we looked from 2,000 arrests occurring in 2008 to 2018 and found 120 patients who had had their cardiac arrests in a supermarket. A high proportion found in a shockable rhythm due to high percentages of CPR, and survival was 27% overall, which is significant, but almost 70% if a public access defibrillator was applied. And using data from VACAR, Brian looked at the characteristics of the patients and estimated that there would have been at least, and this is a conservative estimate, at least 12 additional survivors if PAD had been available to all of those 120 patients. And then when you look at all patients across that time period who were arresting in public locations with viable arrest characteristics, we estimate that we would have had at least 100 extra survivors per annum if they had have had public access defibrillation available in those locations. Then another thing that we were interested or very interested in looking at was what's happening in schools because obviously cardiac arrest in the young, while rare, is devastating and often fatal, and the flow-on from effects from that are significant. And so Brian wanted to look at what's happening in schools and public access defibrillators being applied. And this has been published in Pre-Hospital Emergency Care. So again, highlighting that schools and universities should be able to plan and prepare for cardiac arrest on their campuses. Excuse me. I certainly check with both the schools that my daughters have gone to that they have a defibrillator available. And it's not just having a defibrillator available, but it's also having an emergency response plan. Who knows where the defibrillator is, how, where it's located, how visible it is, and how regularly it's checked. So we extracted data from VACAR again from 2008 to 2019. And over that time period, there were almost 70,000 arrests occurring in Victoria attended by Ambulance Victoria. We excluded patients witnessed by paramedics and patients in non-public locations. And that came to just over 9,000 patients. Of those, we found 131 cardiac arrests that occurred in university locations or schools, and almost 9,000 that occurred in other public locations. And if you look at the baseline characteristics of patients where paramedics have commenced resuscitation and the arrest has been in schools and universities or other public locations, not surprisingly, the age is lower in patients arresting in schools, and they were more likely to receive bystander CPR, had higher rates of public access defibrillation, more likely to be in metropolitan regions, and more likely to have a cardiac etiology. Also more likely, almost 70% presenting in an initial shockable rhythm. And then more favourable survival outcomes as well in patients arresting in schools or universities versus patients arresting in other public locations. If we look at who arrested at the schools, surprisingly the majority were not actually students. So only 22% of the patients arresting in schools were students. The majority were made up of members of the public who were visiting the schools or potentially near the schools when they had their arrest, and it was known that a defibrillator was located in the schools. And then the other were school staff members, parents and grandparents, and we couldn't classify all of them when Brian read all of the patient care records. And then the location of the cardiac arrest, so the majority occurring in a sports centre or field, then in a university or school building, some in the local community, so that's where they've retrieved the defibrillator from the school, and others where we couldn't ascertain. Oh, sorry, when I say local community, that's school children who are out and about. So this really highlights, I think, that it's all very well to have a defibrillator at the school premises, but we really need something portable that's taken to the sports centre or the field when students are participating in sort of athletic activities. And when we look at who actually applied the ED, in 18% it was actually an unknown bystander, so a bystander that we couldn't classify as a staff member or a student, then followed by staff and a very small percentage with applied by students. But what's really distressing, I think, is that 64% of cardiac arrests that we saw in the schools and universities didn't have a defibrillator applied. So this really highlights that we need to be looking at how schools are actually placing their defibrillators, but also the whole emergency response plan that they have around the use of the defibrillator. And what's nice to see, though, is the trends in the characteristics of cardiac arrest, where resuscitation is attempted by paramedics according to location. So the topic is we're looking at schools and university locations, and it's really great to see that there's a significant increase in the public access defibrillation before the arrival of paramedics. So in the first few years when we of data that we looked at, the percentage was only 4.2% getting a public access defibrillator applied when they were arresting in schools. And this was up to 47% in the last 2 years of the study. Still too low, like 50% not getting a defib, but promising that the trend is increasing. And not surprisingly, this is then reflected in the increased survival that we see over time for these patients. So a significant increase in ROSC and a significant increase in survival to hospital discharge. And similar increases in PAD in other public access locations, but not to the same degree that we saw in schools and universities. And this again is reflected then in not as high survival to hospital discharge as we see in the school cohort. And so this is just sort of graphically representing that nice increase over time. So we can see that nice increase in rates of bystander CPR, and then we can see that really nice increase in PAD before the arrival of EMS, and increase in survival. So the blue is schools and university locations, and you can see that really nice increase in PAD before arrival with schools and locations, but a small but not big enough increase in other public locations. And then similar when we see survival to discharge, and you see that significant increase in school, and not as an increase but not as great in other public locations. Again, this is just sort of highlighted when you can sort of overlay the increase in bystander CPR and the increase in public access defibrillation, and that nice correlation with increased survival for patients. So again, really highlighting the importance of public defibrillators being located in key locations. And then if you look at an adjusted regression model to look at the association of arresting in a school versus other locations, you can see that the location was not a significant predictor of outcome in all cardiac arrests and also in non-shockable. But what is the big predictor of survival outcomes is having a public access defibrillator applied. So your odds ratio is 2.16, so significantly more likely to survive if you have a public access defibrillator applied. So one of the key recommendations from this research is not just to have defibrillators on all school and university sites, and obviously depending on the size of the education facility, significant number of defibrillators, but also to have an emergency response plan and really know where your defibrillators are, but also take them to key locations when you're doing sport and things like that. And don't lock them in the school cupboard. Have them available for members of the public to use via things like our Good Sam app. Sort of at the other end of the spectrum, the other thing that we were interested in looking at was whether patients are attending their GP clinics with prodromal symptoms of cardiac arrest. And our GPs equipped to respond to a cardiac arrest. We know in places like Ireland, there's fantastic GP sort of co-responder programs where they go out in rural areas and respond to cardiac arrests. And we were interested in what's happening in our GP clinics, and are patients attending these clinics with prodromal symptoms. And this paper has been published in Medical Journal Australia this year, had a nice editorial written by Siobhan Maston from Ireland, and attracted quite a bit of media attention. So what we were interested in doing was looking at cardiac arrests in GP clinics, and then comparing them with cardiac arrests that occurred in front of paramedics. We felt that was a fair comparison. So you're arresting in front of or near a general practitioner, or you're arresting in front of paramedics. And so we extracted that data and excluded traumatic cardiac arrests, terminally ill patients, and patients where paramedics didn't start resuscitation. And from that, over the time period, we found 6,300 or so cardiac arrests fitting the criteria, of which 216 were in GP clinics, so 6.1%. So when you look at the patient characteristics, there was a high proportion of patients with presumed cardiac etiology arresting in GP clinics compared to those arresting in front of paramedics, a higher proportion in a shockable rhythm. Of those, 37% were defibbed by clinic staff and 63% defibbed by paramedics. So in 63% of cases, they're waiting for the paramedics to arrive before defibrillation is applied, which is pretty unacceptable. And the unadjusted survival was similar in both groups. And then if we look at what the main symptoms were for the patients who attended GP clinics and then subsequently arrested, for whom we actually had data on, so this again was a manual data extraction from our patient care record by Brian. Chest pain is the resounding prodromal symptom. So the main ones are chest pain, sudden collapse in the clinic, shortness of breath, and then sort of general feeling of unwell and nausea and vomiting, the last one. The vast majority had their symptoms occurring within the 1 hour. Blue is patients with any symptoms and the red is patients with chest pain. But you can see, even though it's a small percentage, some patients waited 7 days before, with some sort of symptoms, before actually attending their GP clinic. And then if we look at who actually witnessed the cardiac arrest, if it occurred in the clinic, so the vast majority, not the vast majority, but the majority were witnessed by GP or clinic staff. Others were witnessed by a family or patient or a bystander. The location tended to occur predominantly either in the consulting room or the waiting room. So again, with these witness rates by clinic staff and the locations, it really highlights that having a AED located in the GP clinic is pretty fundamental. So if we look at the characteristics of cases in patients with an initial shockable rhythm, not surprisingly, the ones at the GP clinic were older compared to those witnessed by paramedics, more likely to be in a metropolitan region, lower rates of public access defibrillation. So again, only 63% actually having PAD, and this was compared to, as you would expect, 100% of patients arresting in front of paramedics in a shockable rhythm receiving a shock. So this is reflected in lower rates of ROSC and survival to hospital discharge in our GP cohort compared to our EMS witness cohort. And if we then look to see at predictors of outcome using an adjusted multivariate logistic regression, so adjusting for obvious predictors, we can see that in patients with an initial shockable rhythm, if we compare patients who have wait to be defibrillated by paramedics in the GP clinic, if the clinic staff defibrillated, you were 2.23 times more likely to survive. And if you arrested immediately in front of paramedics, you were 3.4 times more likely to survive. So again, highlighting, the devastating sort of impact of waiting for an ambulance to get there before defibrillation is applied. This is just a graphic representation of showing this nice this is patients who are in a GP clinic. So we see this nice decline in waiting for the paramedics to arrive to apply the first shock. And then we see that inverse relationship with this increase in GP clinics providing the first shock and a nice association with improved survival outcomes. But, even in the sort of 3 years of this study, so, relatively contemporary data, still, over 40% of patients who are arresting in GP clinics are not getting defibrillated by clinic staff, which is pretty devastating for those patients. So we know that VFVT deteriorates with time. We know that public access defibrillation improves outcomes, and it's the answer if you want to be defibrillated in the first few minutes. But does PAD actually improve longer term outcomes? So Brian, again, looked at the long-term functional and quality of life outcomes in cardiac arrest survivors, stratified by who provided the first shock. And this paper is currently under review. So again, highlighting that there's been a lot of work done around the chain of survival space, recognising now that the last link in the chain really is around recovery and rehabilitation and support for survivors. And again, like I said, we're so proud that VACAR is one of the few registries that collects quality of life outcomes on patients. So at 12 months, we contact adult patients and we apply and we talk to the survivor or their proxy and we look at functional recovery with the Glasgow Outcome Scale, and we use the EQ5D and the SF12 to look at quality of life outcomes. And we also ask some key questions around if they were working prior, are they working now, and are they living at home without care, so what their living at home situation is like. And we usually get about an 84% rate each year in our follow-up. So if we look, so again, Brian took data from VACAR to look at sort of this question, excluded, patients of age less than 18, traumatic cardiac arrest, not shockable rhythm, EMS witness, nursing home patients, and ended up with a sample of around 6,000 patients. And so you can show there's some sort of differences in characteristics of patients depending on who provided the first defibrillation. So we divided it into paramedics, first responders, which is our sort of fire first responders or our community emergency response teams, or a lay bystander. And so more likely to be male if you've defibrillated by a bystander, more likely to have a witness cardiac arrest, bystander witness, and much higher rates of bystander CPR, which is not surprising. So if we look at the discharge direction of survivors by shock provider, we can see that you're much more likely to be discharged alive if you are defibrillated by a bystander. And then if you are defibrillated alive, if you are discharged alive, there's a higher proportion you'll discharge straight home and not to rehabilitation facilities. So looks promising in terms of survival outcomes. And if we look at some of the characteristics too around the sort of characteristics of patients depending on who provided the first shock, we have a higher response rate in our patients who were defibrillated by PAD, and this isn't surprising given they're likely to have better outcomes. They had higher levels of education, no difference in their EQ5D visual or verbal analog scale prior to their arrest. So we asked patients to rate how good their quality of life was from 1 to 100 before they had their arrest. So the proportion of patients saying that they were saying a number equal to or greater than 80 was no difference between the three defibrillation provider cohorts. So similar sort of levels of quality of life in the three groups. Slightly higher patients working prior, but not statistically significant in our PAD cohort. So if we look at actual quality of life, with the red being the patients defibrillated by a bystander, in all of our measures, patients who received PAD did better. So they had higher proportions of good functional recovery, looking at the GOS. They had higher proportion of patients stating that their EQ5D was 1, which is equivalent to perfect health, or their VAS via the EQ5D was greater or equal to 80. If they were working prior, they were more likely to be working again at 12 months post their arrest, but these percentages were similar in the patients defibrillated by first responders versus patients defibrillated by bystanders, but compared to patients defibrillated by paramedics were significantly greater and much more likely to be living at home without care. And this is a really nice graph that Brian has produced, which looks at the linear association between time from call 2000 to first shock and how that correlates with a decline in various outcomes. So if you see the first one with the red one, which is living at home without care, as time to first shock increases, that rapidly declines as to whether they'll be living at home without care at 12 months. Similar for a GOS, which is upper good recovery. Similar for the EQ5D and the EQ5D index of 1, indicating perfect health, highly aligning with returning to work, and all significantly time dependent. And then if we look at the adjusted outcomes, so we adjust for characteristics between the three groups. If you compare bystander defibrillation with defibrillation by paramedics, again, all significant outcomes except EQ index score of perfect health of 1 is ameliorated by adjusted analysis, and the SF12 mental component, where greater than 50 is a good outcome, not significant. No significant difference when you look at patients defibrillated by first responders versus paramedics, except in the return to work measure, so more likely to return to work. So we know that PAD early defibrillation is a good thing. We need to get more public access defibrillation out there. So, most services are using sort of app-related dispatch to get first responders to suspected cardiac arrest, and we're certainly using Good Sam in Victoria. But what is sort of the ethics and the impact on first responders in terms of dispatching them to these stressful events? So again, another great study by Brian, where he looked at smartphone activated volunteer responders to cardiac arrest in Australia and New Zealand. So New Zealand also have the Good Sam app, and so we were interested to look at were responders responding when they received an alert, if they weren't responding, why, and were they impacted at all when they went to cardiac arrest patients. We collected data from St John, New Zealand, and from Ambulance Victoria, and there was a Good Sam survey, a survey sent out to Good Sam responders 2 weeks post their alert and 6 weeks post their alert. And then if you see at the combined, we had almost 2,000 responses from Victoria and almost 1,500 from New Zealand. We restricted our analysis or our surveys to responders who are actually alerted, were interested in their characteristic and their reasons for accepting or not accepting. And there was a PTSD screening tool applied at both points of contact. You can see the vast majority of responders were actually affiliated with an emergency medical service, so off-duty paramedics basically, and then health professionals, police and fire, non-emergency type like Royal Flying Doctors Service, and then some who were completely not affiliated with any type of health service or emergency service. The vast majority of responders had said that they had CPR training in the last 12 months. Both in New Zealand and Victoria. They were quite active in terms of how often they had performed CPR over their lifetime. It's reflected in the fact that we're using off-duty paramedics, so they're exposed to cardiac arrest and they're exposed to CPR. And so if we look at the response to the Good Sam alert, similar responses in both Victoria and New Zealand. So high proportion saw the alert, and then that whittles down to around 40% accepting, and then around 28% arriving, and it gets whittled down to 16, 15, 13% actually providing care. The main reasons for not responding is that they didn't hear it. So that's good feedback for the Good Sam app, and other obvious reasons like they weren't near their phone, the alarm didn't go off, they were actually working at the time. Again, just highlighting this, that they were either working or had family commitments such as childcare, or they were already responding to an event, were the main reasons why they weren't available for the alert. And not surprising, and this is why we need first responders that can go into patients' home. The vast majority of patients there where a Good Sam responder was alerted to were in private residences. And they did get there. The majority did CPR and generally hands only, but given the nature of the responders, some were doing 32 compressions. And this is, I think, quite telling, this slide. In terms of providing PAD to patients when Good Sam responders got there, it was only around 12-13% that were actually providing a PAD, and then of those, the defibrillation whittled down to between 7 and 4%. And so, we really need to question the effectiveness of the program if the rate of defibrillation is low. And so when we actually surveyed the responders to see how they felt about happy, the overwhelming response was that they were happy to help, almost 90%, and some of them saying, it took a bit of courage, which is obviously fair enough. If we can see the odds of accepting the alert and providing care. So, one being no association. The things that were more associated with that were CPR training in the previous 12 months and having performed CPR before, which is not surprising in terms of confidence in responding to an alert. And the interactions with the fire service varied between the two countries, which is interesting and probably reflecting of culture and other nuances. And also debriefing was different between the two countries, and this is predominantly because Victoria has a very active debrief when someone is responded through the Good Sam app. But what's really encouraging is that the rate of PTSD at 2 weeks post-alert was extremely low, and we just had a very low, less than 1% who were saying that they had some from an event at work, but it wasn't related to the Good Sam dispatch. And at 6 weeks, we had just one patient saying that, one responder saying that they had PTSD from the Good Sam alert. But on sort of questioning them, there were a whole lot of other things also going on, which made them sort of more vulnerable to that. So really reassuring that sending these lay responders, although often off-duty emergency medical service people, out to people's homes in very stressful environments, but we don't seem to be seeing an impact on certainly any sort of post-traumatic stress disorder that this is causing these really valuable first responders. So recommendations from this research. Increasing PAD is essential. We can see that, the impact on survival and health-related quality of life, getting back to work, all of that is essential. We need to be looking at key locations. It's sort of unbelievable that every GP clinic doesn't have an AED. We know that sending out first responders is safe, but we saw a low application of AED when first responders were dispatched. And, this has been reflected in conversations as well, where paramedics who are part of the Good Sam program say, I just want to get to the house and start something rather than going and retrieving a defibrillator from somewhere first. So, the answer to that, I think, is really portable AEDs that, that Good Sam responders are equipped with, they're cheap and affordable, and we ask them to have them with them, take them with them wherever they are. And we're actually going to trial that in collaboration with New Zealand with equipping our Good Sam responders with small portable defibrillators. So watch this space. Basically, when we're thinking about recruiting, who should we recruit to the Good Sam or the other first responder programs? Brian did a nice piece of work which was published in Resus last year, and it basically showed that a medically trained, like nurse, doctor, paramedic, who were providing the CPR in a public setting, survival increased by 40%. So when we're looking at who we're recruiting to these first responder programs, we need to consider, the likelihood of responding and the quality of their CPR. So thank you very much for having me for this webinar. I hope I've convinced you of the importance of PAD and the nuances around how we might get more defibrillators applied to patients out there. Thank you so much.
Thanks, Karen.
Oh, that's excruciating to watch yourself like that for 40 minutes. Yeah, it's a good question, and we definitely haven't reached saturation in any way, shape or form in terms of the number of Good Sam responders that we've got. So I think we really need to innovate in that space. We've been talking about things like CPR consoles, sort of like, arcade game type things where you could put in high foot volume places, and people could, have a go at CPR, and after they've done it, it could sort of pop up saying, oh, you're not bad at this, you should consider being a Good Sam responder, sort of thing. So I think, and then also the key is getting them to either retrieve or know where, either carry or know where a defib is. And we need to be legislating in terms of defibs in school and CPR training in school. It's a no-brainer, and other countries are way advanced compared to us in that space. I think some of the onus should be back on the manufacturers with that as well, to sort of have them advocating in that space when people purchase defibs, that they consider where they're placing them and making sure that they're, available. We know the vandalisation, that things being vandalised is extremely low and rare. So they don't even need to be in a locked up cupboard sort of thing, and they need to be registered with the ambulance service defib register as well. So there is a huge amount to do in that space as well. And I see Simon's comment somewhere about building code. I completely agree. When there's new buildings, high rise and all the fire, fire extinguishers and everything that need to be there, we should be mandating that a defib has to be there, and there needs to be some sort of plan around that as well. So there's so much we can do in this space. Yeah, there actually was a bit of media about it, and and then there was some sort of discussion by the college saying that they're looking into making them mandatory. I mean, historically they were very expensive, but that's not the case now. So it really, it really needs to be mandated. It's a no-brainer. Your plans need to be tailored, so not every community or every place is the same. So I think we need to be looking at specific data around communities, areas with high incidence, low bystander CPR rates, understanding what's driving that, and and actually tailoring interventions specific to those communities. Communities with higher Indigenous populations, then you need to engage that population. So I just don't think it's a one size fits all type approach.
No, I agree with you. I know Professor Bridget Ducker has done some really interesting research in the space in New Zealand and how we might target our rural communities. So kind of watch that space. The obvious question that I guess we have to ask is the impact of COVID-19 on both on your data and obviously and your survival rates. What's your predictions?
So we published our 2020 data, and it's pretty depressing, and this year is even worse. So so there's obviously issues that more people are arresting in homes, so that you don't have that kind of that PAD and bystander intervention, but there's delays in terms of paramedics putting on PPE and all sorts of things. So it's been pretty dismal, and it's hard to know what to do in those circumstances. I mean, we suspended Good Sam for a period, so that has a flow-on effect as well. So we're just really hoping that we're, coming into 2022, we can sort of, focus on how we sort of get back on track.
Great, thank you. Good Sam is obviously having a great impact. The uptake of Good Sam is obviously an ongoing challenge for both Ambulance Victoria and St John New Zealand and Wellington Free. What's your plans around marketing Good Sam to get a greater proportion of people taking it up?
There's all the obvious things that happen, particularly around Restart a Heart Day and things like that. And obviously COVID has not been conducive to extending membership. I really think that we probably don't use the platform itself enough to engage and promote and, hassle people around. Have you told your friends about this? Have you, so the platform itself, I think, is a real opportunity to engage the community that we probably haven't explored well enough. But yeah, it's an ongoing, I think, and once you recruit, you need to maintain engagement. You need to be checking in, and just, looking at CPR. We don't require now that you have to have recent CPR training, but, I think gently promoting that would be a good thing. When we look at our data, it obviously offers an advantage.
Peter puts a really good question into the chat. Why is Good Sam not rolled out in other states in Australia?
No comment.
Yeah, but I think just in response to Peter, I think most states and territories are looking at first responder activation apps. and a number of other states have got some similar apps to Good Sam. I would imagine over the next few years we'll see more and more states and territories pick up first responder apps. It is it's not as simple as just applying an app to people. It's a big program, and it's part of a much bigger strategy. But we're heading in the right direction in that space for sure.
Yeah.
It just takes time. So with the introduction of these kind of disposable, portable / iPhone-size AEDs, Karen, what's your thoughts in regards to the impact they're going to have?
Potential to be a game changer. The ones that we're looking at are sort of single use, small enough to encourage the responders that we enroll in the trial to carry it with them at all times as much as practicable, and they're affordable as well. So in terms of individuals, households purchasing them as well, it's so I think in terms of innovation in the defibrillator space, I think the next few years is really going to allow us to make a real difference.
Great, thank you. There's a few more comments in the chat around Good Sam, which is really good. I think the more people that hear about this, the more likely services will pick it up. There is that whole integration piece within to the comm centres, which is a very challenging piece of work, but it is fundamental.
Yeah.
Those were all my questions. I think that firstly, I just want to thank our listeners and watchers. We have had quite a large audience today, which is great, and lots of really interesting chat and the sidebar, which is fantastic. Karen, as always, great presentation, great info, and again, amazing stuff coming out of AV. And congratulations to your team. We look forward to seeing you present at our next CAA Congress later in 2022, hopefully. There is let's fingers crossed we get there in person. Yeah, absolutely. Just for the benefit of our audience, our next CAA webinar, which is on the 14th of December, is High Performance CPR, an insider story from Mike Helbock from the US, being sponsored by Liddell. So I look forward to seeing you return to hear from Mike in relation to his story around high performance CPR and CPR measurement. Thank you again. Thanks to the presenters. Thank you for listening. And we look forward to seeing you all on the 14th of December. Take care.
Thanks for joining us for Public Access Defibrillation, Impact on Patients and Responders, presented by Professor Karen Smith and proudly supported by Philips. Please join us for our next webinar on the 14th of December for High Performance CPR, an Insider Story, presented by Mike Helbock and proudly supported by Liddell. In the meantime, be sure to follow us on social media to keep up to date. Twitter at CAA Australasia, Facebook and LinkedIn, the Council of Ambulance Australasia. Thanks so much for joining us, and we'll see you next time.